AVRT is atrioventricular reentrant tachycardia. The example for this is Wolff-Parkinson-White syndrome, WPW. In WPW, there is an abnormal pathway or accessory pathway between the atria and the ventricles. It is known as bundle of Kent. When a normal stimulus goes through this bundle of Kent, see, and it also goes through the AV node, but through the AV node there is a delay, but through this bundle of Kent there is no delay. So the impulses through the bundle of Kent will excite the ventricles first. If there is a premature beat, the impulses will reach this bundle of Kent. What will happen? Because of the normal stimulus which was before this premature beat, the bundle of Kent will be in refractive period now. If it is in refractive period, then the impulses cannot pass through this bundle of Kent. So the impulses will pass through AV node only, and when these impulses will reach here, the bundle of Kent would have come out of its refractive period, it would have recovered. So the impulses can now travel through this bundle of Kent and it can go to the AV node. So this is how re-entry occurs in Wolff-Parkinson-White syndrome. Now let's go to AVNRT. What is AVNRT? AVNRT is AV nodal reentrant tachycardia. It occurs in the AV node. There are two types of pathway in this AVNRT. One is alpha pathway, another one is beta pathway. Alpha pathway is slow conducting pathway and it has short effective refractive period, but fast conducting beta pathway is fast conducting pathway and it has long ERP, long effective refractive period. Now what happens if the impulse comes like this? See, through the slow pathway it will be going slow. Through the fast pathway it will what will happen? Through the slow pathway it will reach late, so it is blocked by this impulses from the fast pathway. So the impulses from the slow pathway are blocked by this fast pathway. Then if there is a premature beat, a stimulus is coming yearly after this normal stimulus, what will happen? See, through the fast pathway it has long effective refractive period and in the slow pathway there is short effective refractive period. So when there is premature beat, what will happen? The alpha pathway having a short ERP would have recovered, so impulses can travel through this slow pathway, alpha pathway, but it cannot travel through this fast pathway because it has long effective refractive period. So the beta pathway would have not recovered from its effective refractive period, it would have not recovered, so impulses cannot travel through this fast pathway. Now the impulses will again go here. Why? Because from the slow pathway, when it would have reached here, or when it would have reached here, the fast pathway would have recovered, it would have come out of its refractive period, so the impulses can again travel through this fast pathway. So this is how the re-entry occurs in AVNRT. There are two types of AVNRT. One is typical AVNRT, another one is atypical AVNRT. In typical AVNRT is, see, we saw in typical AVNRT what will happen? The impulses coming from SA node will travel through this slow conducting pathway first, and then it will again re-enter through the fast conducting pathway. The slow pathway acts as antigrade conduction, and through the fast pathway there is retrograde conduction. So it is known as slow fast AVNRT. Why? Because the antegrade conduction is through slow pathway and the retrograde conduction is through fast pathway. So it is known as slow fast AVNRT. In atypical AVNRT is opposite to that of the typical AVNRT. What will happen? There is fast slow AVNRT. The antegrade conduction will be through the fast pathway and the retrograde conduction will be through the slow pathway. That's why it is atypical fast slow AVNRT. Let's see about the ECG. In AVRT, in Wolff-Parkinson-White syndrome, what will be its ECG? See, we saw here that the impulses through the bundle of Kent, there is no delay in conduction through the bundle of Kent. So, it will exit the ventricle first. So, what will happen? The PR interval will be shortened. Okay. Then, what again can happen? As the impulses from the bundle of Kent are exiting the ventricles first, and then through the AV node the impulses come and exit the ventricle. The QRS complex will be slightly different here. It have a slurred upstroke in QRS complex. It is known as delta wave. It will look like see, this is delta wave. Okay, and there is widening of the QRS complex. You can remember this through WPW. W for wave. Wave is delta wave. P for PR interval shortening. And then another one W for wide QRS complex. Okay. What happens in AVNRT? AVNRT has both typical and atypical. Typical is the majority, which has 90%, and atypical is 10% cases, seen in 10% cases. What happens in typical? Most of the times in typical AVNRT, there is the P wave is buried. The P wave is buried under QRS complex. So we cannot see the P wave, but there will be only QRS complex. Or sometimes the P wave can represent it as pseudo S wave and pseudo R wave. See, this is pseudo S wave. It is seen in lead 2, 3 and AVF. The pseudo S wave is seen lead 2, 3 and AVF, and this is pseudo R wave. Pseudo R wave. It is seen in lead V1. So this is the ECG features of typical AVNRT, and atypical AVNRT will have a P wave before the QRS complex. Before the QRS complex, there is a P wave which is retrograde P wave and inverted. This is seen in atypical AVNRT. What is the treatment for this? In AVRT, Wolff-Parkinson-White syndrome, radio frequency ablation we can do radio frequency ablation of the accessory pathway. So bundle of Kent we are going to destroy the bundle of Kent. This is done in Wolff-Parkinson-White syndrome. And in AVNRT, we can destroy through radio frequency ablation, we can destroy the alpha pathway, that is slow pathway. Or what all the other things can be done? See, you can tell the what we have to do. We have to, what's happening, there is re-entry in the AV node. So what can we do? We can decrease the conduction through the AV node. So we can stimulate the vagus. How can we stimulate the vagus? By carotid sinus massage. And we can do it through Valsalva maneuver. Okay. To block the AV node, what can the drugs we can give? We can give adenosine. See, what adenosine can do in the AV node, adenosine receptors, A1 is present, it is GI, so it will inhibit adenyl cyclase, ATP to cyclic, AMP will not be formed, there is no protein kinase A. So the calcium channels, due to it is GI, it will inhibit this calcium channel, there will be no entry of calcium into the AV node, and it will open the potassium channels and potassium efflux will take place. So because of this, there is decreased conduction in the AV node. And other drugs which we can give is calcium channel blockers, which will act on AV node, like verapamil, diltiazem. Thank you.